Pleasure to open COLDA 2019. This is really a prime opportunity for us to share our lessons learned, be honest about our challenges as well as our successes, and really know that elimination is very much a team effort. I think it's very appropriate that we're talking about eliminating hepatitis here in Cairo, Egypt. We're going to be talking a little bit about the burden of disease, why we have elimination goals, the key interventions, and the progress as well as the challenges to those elimination goals. I had the opportunity yesterday to go to the Egyptian Museum and learn about the embalming process of pharaohs and how they have a special jar for the liver, and they have a protector, Seti, who is then protected by the goddess Isis. So it's nice that liver protection has always been part of the Egyptian culture, and as I'll show you in a moment, it's living up to that tradition when it comes to hepatitis C elimination. We're going to be talking about hepatitis B and hepatitis C today because of the viral hepatitis. They are the major causes of mortality, 96%. 800,000 deaths from hepatitis B globally, and almost 600,000 deaths from hepatitis C, from cirrhosis and liver cancer. That reflects the large burden of prevalence. We have about 257 million people living with hepatitis B chronic infection, 60 million of those in the Afro region, 21 million in the IMRO region, which includes Egypt and North Africa. Major risk, as I'm sure all of you know, is related to transmission at birth or through horizontal transmission before the age of 5, largely that leads to chronic infection. 71 million people living with hepatitis C, 11 million of those in Afro, 15 million of those in IMRO. Major risk or blood exposures in healthcare settings, far and away the major cause of ongoing transmission of about 1.2 million infections a year, but the highest prevalence among people who inject drugs as a subpopulation. Hepatitis B and hepatitis C is responsible for more than 2 out of every 3 deaths from liver cancer, the 4th leading cause of cancer deaths globally. And as you can see, prevalence of the rate of mortality is high in countries of Africa, here in Egypt related to hepatitis C, parts of Europe, and in Asia. Now, troubling, we have over 1.3 million deaths now, but based on projections from the Global Burden of Disease Study, if the status quo does not change, by 2040, more persons will die of hepatitis B and C than TB, malaria, and HIV combined, 2.2 million versus 1.9 million deaths, respectively. So we need to change the status quo. And because of that concern over these trends, it led to the formation of elimination goals by the WHO, those endorsed by the World Health Assembly. Now, why do you set elimination goals? There's a long history of that. Number one, you have to meet certain criteria for a disease considered to be deemed feasible. Hepatitis B and hepatitis C virus biologically fit those criteria. And then you have to have technical feasibility because you have effective interventions. In our case, we have hepatitis B vaccine, safe and effective. We can interrupt transmission through blood-borne exposures, and we now have treatments for hepatitis B, virologically suppressive, 50% reduction in mortality, and as we all know, curative hepatitis C, several pills a day, 2 to 3 months of treatment, over 95% cure, large reductions in liver cancer and mortality risk. Also, importantly, elimination is really a call to action. It signifies a large public health problem that needs urgent attention, and it intends to help bring partners to the table. And we're going to see some examples of partnerships here in a moment. And above all, disease elimination achieves the ultimate goal of public health, which is health equity, so that everyone in a community or a population benefits from life-saving interventions. The WHO has recognized these key interventions of vaccination, interrupting blood exposure, screening, and treatment, and are tracking those. This is examples of the status for the Afro region and the IMRO region, showing some deficits that we're going to be talking about in terms of low birth dose coverage in the case of Afro in particular, continued exposures to unsafe injections in healthcare, particularly in IMRO, and both regions, as well as globally, having issues with poor diagnostic rates and access to treatment. Hepatitis B vaccination is the cornerstone of hepatitis B prevention when it comes to incidence and achieving that elimination goal of a 90% reduction in incidence by 2030. The cornerstone is that 3-dose infant vaccination series. Then you put on top of that birth dose within 24 hours of birth, preferably. Maternal screening so that additional interventions can be added, hepatitis B immune globulin, and perhaps antiviral prophylaxis for women of high viral load. We have high coverage with the 3-dose infant series as shown here, and we need to do a better job globally of improving birth dose coverage, particularly in Africa, as I'll show you in a moment. Now, certain parts of the world where prevalence is high have done a remarkable job of implementing high-dose coverage, beginning with that birth dose and continuing on to the completion of that infant vaccination series, particularly in the Western Pacific region, where you've had large declines in prevalence as you've had rising coverage of birth dose and infant vaccination, including in China, where 50% of all people with hepatitis B live. Truly a remarkable accomplishment for that whole region as a result of them setting goals collectively, tracking progress, and sharing their progress and their lessons learned for their implementation strategies. So now let's look at Afro. Afro has done a good job of implementing hepatitis B infant immunization, but continues to have low hepatitis B vaccination coverage for newborns. Now we have some opportunities to change that. First of all, why is that important? Well, newborns have the highest risk, if they become infected, of developing liver cancer in later life, in contrast to persons infected at an older age. So they're a particularly vulnerable group. Now, you already have a good infant immunization program here as your backbone, but now you need to extend that into maternal and child health care programs. Fortunately, as many of you hopefully know, the Gavi Executive Board approved support for birth dose for Gavi-eligible countries, providing some funds now for reimbursement of changing maternal and child health programs to implement that vaccine. So that's really good. Plus, we have a rich repository of implementation strategies that countries can now draw on from Asia, as I've already mentioned in particular. So what are our challenges? Number one, the cost of vaccine is considered fairly low. However, countries will be expected to pay for it, so that will be a cost that they'll have to bear. So I know already some countries are looking to wanting to do serologic surveys so that they can gauge the cost effectiveness of implementing the birth dose. So that's another issue that needs to be addressed. You have a high proportion of births born at home, that occur at home, 40% here, so that presents extra challenges. And so you're going to have to really require a lot of implementation and changes in your maternal and child health programs. So you have new opportunities, you have the toolkit, but we really need to work together to get this high on the priority list at the country level. One of the success stories of elimination has been the reduction in transmission in healthcare settings. Large reductions globally with improvements in infection control. However, still 1.2 million people become infected through exposures in the healthcare setting. So we still have a ways to go, particularly in countries such as Pakistan and even in Egypt, which has done a remarkable job of improving infection control, but still has issues because of societal preference for injections over oral medications that are equally effective, and other issues that have to be addressed. The other challenge that we have to overcome is for the subpopulation of people who inject drugs, that there's not adequate harm reduction, access to clean injection equipment, access to drug treatment around the world, but particularly low in many African countries. Now, and then that gets us to diagnosis and treatment, the other elements that are necessary to reach that elimination goal of mortality of 65% reduction by 2030 globally. And as you can see here, we have very low diagnostic rates and treatment rates for both hepatitis B and hepatitis C, even though we now have these new curative treatments for hepatitis C. They're still only been available to us for about 5 years. Now, for World Hepatitis Day, the WHO put out a new modeling estimates showing how with affordable diagnostics and treatment, using a very aggressive approach in testing large segments of the population, elimination can be achieved at a cost of about $67 billion. Now that may seem high. I would certainly like to have that in my bank account, but that's only about a 1.5% increase in the overall cost of integrated health care. For most countries, it's highly cost-effective or cost-saving. It's actually more cost-effective or cost-saving than HIV elimination. And you're going to have a large health benefit, as you can see there, with an averting over 4 to 5 million deaths from viral hepatitis. But to achieve that, we have to improve diagnostics and treatment. Now, they recognize that there are different ways to go about this, depending on socioeconomic and healthcare characteristics and capacity. That for high-income countries, it's basically expanding access and budget planning to and physician training, clinical training. Middle income, again, through negotiations and identifying what's affordable for diagnostics and treatment, these elimination programs can be implemented, and then recognizing for low-income countries is where some external resources are in greatest need. So let's look at some examples of that. Case of Australia has done a remarkable job in many ways. For the subpopulation of injecting drug users, Australia is out in front of most countries in the world in providing harm reduction and now treatment as prevention for people who inject drugs. As a result, their prevalence of hepatitis C among that population is lower than most other countries. They've also, through price negotiations, got a very affordable price for the country where they, at a set price over a certain period of time, they can treat as many people as they can find. So that's a big incentive to test and to refer for care. And they are extending testing and treatment out into a variety of different settings. Japan, which had a large number of people infected as a consequence of poor screening of the blood supply, progressively have implemented a variety of interventions, both for hepatitis B and hepatitis C, as you can see there, beginning with blood bank screening to progressively more open and assertive testing for hepatitis, development of treatment centers, a referral center in every prefecture in Japan, and really making this a high priority for the healthcare system. And as you can see there, as a result, the prevalence has dropped in response to those interventions. What about the United States? We had about 3.4 million people living with hepatitis C at the last National Health Survey. That was the one that, before this was updated, in the most recent survey, it shows that that prevalence has declined to 2.4 million. And importantly, an important marker of elimination of hepatitis C is for national surveys, is the percent of antibody positives that are found to be HCV RNA positive, because I think that's a good marker for cure. And in the case of the US, that has dropped from 73% to 57%, indicative of that treatment effect. Now, we've identified, as has others in other countries, some of the key strategies for improving testing and linkage to care. Provider education, of course, reflex testing, so you use one specimen to test both antibody and HCV RNA, performance incentives and indicators to feed back into the system for quality improvement, case management, importantly, co-localization within primary care, corrections, and other systems. And of course, the therapies have to be there for people to get treated. In the case of France, they have long had a very robust HCV testing and treatment program. Again, they progressively dropped their restrictions to treatment, and as a result, more and more people have been treated, and now they're testing all adults for hepatitis C as well as hepatitis B. Got this slightly out of order. I did want to acknowledge really the leading elimination program in the United States, which is actually among one of our indigenous people populations of the American Indian Cherokee Nation, which in 2014, before we had a global goal, they set elimination goals for their population. They moved to test all adults. They've tested almost 2/3 of all adults in the Cherokee Nation. They have moved to training a variety of different clinicians, including pharmacists, to deliver HCV treatment. They have found a way to pay for both diagnostics and treatment within their own health system. And now they're doing contact tracing to find people who have risk for ongoing transmission, particularly among people who inject drugs. And they have strong political commitment, as evident here by the quote from the chief of the Cherokee Nation. The other change in the U.S. is that we are just announced last week, the U.S. government has recommended in draft form that all adults be tested for hepatitis C in the age group shown here, whenever they go into primary care at no cost to them. So this expands from the birth cohort strategy to a strategy of testing all adults. And this is in part reflecting a tripling in incidence among young adults because of an increase in injection drug use behaviors related to our opioid epidemic. And you can see that it will have substantive health benefits that have been shown to be cost effective in models that we did at CDC. Another country, Malaysia, government action, political movement, changes in policy, expanding access to free treatment. National screening campaign just launched this year in collaboration with key partners, including FINE, which was part of our workshop earlier today. India, a very high prevalent, obviously a very large population, now have developed a national viral hepatitis control program, have developed a national action plan for combating hepatitis, both hepatitis B and hepatitis C. I think it's very good that it's a comprehensive one that includes vaccination, injection safety, as well as screening and treatment. They have a very robust subnational elimination program in the state of Punjab that's really providing some lessons learned for their health system within the country. So it's very remarkable that a high population country such as India is moving toward elimination programs development. Now let's look within the regions represented in the room today. Rwanda announced an hepatitis C elimination program in December of last year. They have begun to systematically screen all adults over the age of 18. They're seeking to improve injection practices within healthcare systems. They have found ways to lower the cost of diagnostics to about $2 for hepatitis B and hepatitis C screening, and about $8 for HCP PCR testing. They have prescribing physicians trained in district hospitals to deliver HCP therapies at about $80 per treatment course. And now they're training nurses so that the treatment capacity can be increased. And they developed a number of partnerships within the country, both private and public, as well as some international support. So Rwanda is really a very remarkable example of the elimination program development in sub-Saharan Africa. Pakistan has a very large prevalence of hepatitis B, but also of hepatitis C. They announced a development of a national action plan for hepatitis elimination in observance of World Hepatitis Day in July of this year. It was a very high-level political expression of support, seeking to screen over 100 million people in the country in the next few years. They have already achieved remarkably low prices for their hepatitis C treatment. The challenge now is to lower those diagnostic prices, as I've already given you an example of, as possible in a country like Rwanda. They are bringing together coalitions internally, including with a variety of sectors, not just healthcare, but also other industry who is seeking to join this national effort. As I'll show you in a moment, I think they really, being a high population, high prevalent country, they really have a opportunity to learn from Egypt as to how to go about setting up an effective system. So let's talk about Egypt. For many years, Egypt had the highest prevalence of hepatitis C. But thanks to their progressive action, that prevalence has dropped. So probably Pakistan probably has the country of that size with the largest prevalence. They, for a number of years, have had a hepatitis elimination plan. Over a number of years also that they have developed over 60 treatment centers for patients to be referred for state-of-the-art treatment, and they have reduced the cost of treatment after the licensure of the new all-oral therapies. So there was already a lot of awareness going on. They already had serologic surveys documenting their prevalence, and they have an excellent data management system to track testing and treatment outcomes. And that's the data I'm showing you here. What really put this in the fast lane for elimination is the commitment of the president, El-Sisi, to elimination and moving that elimination goal from 2026 up to 2020, and really putting the government on notice that this was a high priority. And I think people have responded in the government and in the society, and I look forward to several presentations that will give you more information about the Egyptian study. But basically, they have screened, just in the time period shown here, over 49 million persons. 2.2 were HCV positive, 1.6 million were viremic and have received treatment. And at the prices shown here to make it very affordable for Egypt, and this effort is continuing. As part of our global hepatitis elimination program at the task force, for World Hepatitis Day, we acknowledge the work of hepatitis elimination champions who don't always come to the podium and have the visibility to describe their remarkable work. And thanks to Manal and Dr. Wakid, they nominated Dr. Kabil, who's been managing this remarkable program since its inception in 2006 and really has been responsible through his excellent management in the treatment of over 2 million people. I don't know if he's in the room today, but since I am in his hometown, I did want to mention him as a remarkable individual. Thank you. Thank you. Egypt is not stopping within its borders. It recognizes it has built up a body of experience and technologies that can now benefit others. So through a presidential initiative, they are seeking to help treat 1 million persons for hepatitis C in 18 African countries. They are doing this with public-private partnerships with companies like Farco and others. They're seeking to improve access to diagnostics as well as to therapies and to work with WHO to provide technical assistance. I was at the Hepatitis Elimination African Hepatitis Summit in June, where the Minister of Health, Dr. Zaid, announced that Egypt would support treatment of all people with HCV in the country of Uganda, and the Minister of Health, Dr. Asing, was very appreciative of that support in her remarks in kind. So just so show you that partnership is in motion, and partnerships are important for us to work together. So I think hopefully I've showed you the essential components of effective elimination: data, plans, civil and political support, capacity to deliver interventions, financing models, integrating services within existing health services, and looking for and recognizing opportunities for operational research. What we're trying to do, what I'm seeking to do at the Coalition for Global Hepatitis Elimination, is to build a community of practice that's in place for other global disease elimination initiatives, but has not been for hepatitis, where we really are sharing information globally, getting to know who is working on those interventions, and really continue these conversations. So these conversations don't end after these types of meetings adjourn, but rather we continue these relationships and information sharing throughout the years until our elimination goals are achieved. We already have a number of countries and civil society programs signing up and sharing information, and I encourage and invite all of you to share and join in this community of practice. As part of that, we look forward to working with WHO and other partners in health, CHI, and national programs, subnational programs directly, to recognize their technical assistance needs and see how we can help them overcome those challenges. One big challenge is strategic information. Since the strategic information systems are particularly poor in Africa, how can we do a better job in getting the data to understand what's important, what are the priority interventions, and how well things are working. I have to say one big area that I didn't include in the efforts ongoing has been efforts around hepatitis B testing and treatment. We have effective, cost-effective therapies, but they aren't being applied in countries of high prevalence such as in Africa. Some of that is a concern about whether the US and European guidelines are applicable to Africa. There's a problem with the cost of testing and the availability of that. Because not everyone needs treatment, there's concerns about retention. So we really need improvements in models of care for hepatitis B. So we don't want to lose sight of that in the rush and excitement toward hepatitis C. We have to recognize the operational research needs for hepatitis B. While we wait for this bench research to give us a functional cure, we need to do all we can to help people with the tools we have. So in summary, hepatitis B and hepatitis C are major causes of death and liver cancer. The elimination goals we have are feasible, and there are opportunities for major improvements in health, with 4 to 5 million deaths averted with these elimination programs. Hopefully I've given you an example of model programs from literally all over the world that are showing you that progress toward elimination is happening, and that those programs provide lessons learned. And we need to begin to work together and be open and honest about what is working and what kind of help we need, so that we really can work together and achieve elimination that I believe is possible for every country represented in this room and globally. Thank you very much.